I'm very excited to introduce our next speaker, Paula Houston. So she brings over 20 years of experience in health and human services, including prior leadership roles as a clinic manager at Carolyn Downs Family Medical Center, executive director of the Meredith Matthews East Madison YMCA, CEO of Sound Generations, and even a short stint running her own fitness business. And she obtained a master's in health administration from UW School of Public Health and her doctorate in educational leadership at Seattle University, where her dissertation explored the use of complementary and alternative medicine among African American breast cancer survivors. And we're very fortunate that she was hired as the Director of Healthcare Equity of UW Medicine in 2017 and promoted to Chief Equity Officer of UW Medicine in July 2020, where she works to increase workforce diversity, decrease implicit bias, engage our communities as partners, and deploy targeted quality improvement and healthcare services to marginalized populations. And she's going to share with us today some more information about the amazing work she's been doing on an equity impact review tool.
Great. Well, thank you very much, Anna, for that very nice introduction. And thank you for having me here. Yes, today I am going to share with you the result of some work that our team had been doing really from the beginning as we began talking with people and trying to understand what did people need to better do their jobs to help us advance our healthcare equity mission here. And one of the things that became clear is that people really didn't have a way to have a structured equity lens on the work that we're doing, being it policies or practices or programs, recruitment and retention efforts. And so having been a part of other organizations and partnering with other organizations and just aware of other organizations that were also struggling with this, we realized that some sort of an equity impact analysis or assessment tool would be useful for our colleagues here at UW Medicine. And so we went about exploring what some of those were out there and realized that there really wasn't one that was really tailored for a health system and an academic health system for that matter. And so we went about developing one, and pleased to say that our dear late great colleague Pat Dawson led our team in developing what I'm going to share with you now, which is our equity impact review tool. So I'm going to go ahead and share my screen. Hold on. Why did that not work? That's what I want. There we go. Okay. So what I'm going to do is just walk you through our tool, and then we'll have an opportunity to have you ask questions after that. So as I said, the tool was really developed as a way to allow us to really actualize our work and our commitment on being an anti-racist, inclusive, equitable organization and improving the outcomes for all of our patients, and really having a framework that will allow us to accomplish these goals within that mission. And it helps us to have a structured way to support our work and make sure that equity is a priority in all that we do. So the purpose of it is to ensure the equity impacts are systematically and rigorously considered in all of our organizational decision making. As I said, it's for policy, not just policies, but programs, practices, recruiting, among others. Furthering our goal of UW Medicine as being an anti-racist organization, we want to make sure that it's something that all leaders have access to and understand and can use on a regular basis. And it has us have the ability to have a check on our policy making, our financial investments, how we are allocating our resources, and other activities that will significantly influence us as a workplace, our community, and our values and norms and productivity. So when and where and how to, when and why to use it. If you are making a change or to something, a policy or a practice, how do you prioritize it? When you're budgeting, how do you prioritize and decide which items to cut and which items to which items to change and which items to keep? Personnel, who to hire, retain, promote, and develop in the policies, your practices. It helps us to look at the impact of the who's going to be affected, looks at our clinical practices, who's going to be affected, what might unintended consequences be. And then it really helps us to continue to have that that equity focus on QI and safety. As we say, there's no safety and there's no QI if we don't have equity. And I am so sorry, I am gonna have to stop for 1 second. That's the beauty of working at home, right? My sincerest apologies. I was having work done on my house and I knew that it was going to get noisy and somebody was going to need something just as I started this presentation. So, again, I was just at, we really want to make sure that we have equity at the forefront of all of our QI and safety, efforts, because we say there can be no QI and true safety if we don't have equity in our system and when we are looking at our policies and practices. So there are a couple of different equity frameworks that we've used as we develop. This one is the distributional equity, so the fair and just distribution of benefits and burdens. So the historical inequitable distribution of burdens must be taken into consideration, and this may result in unequal but equitable distribution of resources. Then there's process equity, the inclusive, open, and fair access to all of the decision processes. And that's where we really think about who's going to be benefited, who's going to be burdened, and who's at the table, whose voice is not at the table and therefore missing, which means we may be missing very important points that might influence how we make the decision and certainly would influence the effects of the decision. And then there's cross-generational equity. The effects of current actions to future generations may include income, wealth, health outcomes, real estate, redlining, resource depletion. Many of you hear that, in our Black communities here in the United States, there's not a lot of generational wealth that's passed down because of decisions that were made, such as things like redlining. So this process, we're rolling this out as a pilot. Right now we have 10 different departments who are formally piloting it in that they have a specific policy or program or project or practice that they are working on, and we are meeting with them monthly to talk about their progress, and they will help us to tweak the tool and refine it, and so that it can be exactly what we need it to be. However, lots of other people have been interested in the tool and so have started using it as well, but we do have 10 people that are currently in the formal pilot. We'll probably meet with that group a couple, 3 more times, take back their feedback, refine the tool, and then put it out as a final. And obviously, as with many things we do, we will continue to refine it as we see the need. One of the things that has already come out of the pilot is that people have asked for a shorter version than what I'm about to show you. But we're really wanting people to use the longer version so that they have a very clear understanding of the process and all the questions and why they're asking the questions. So now kind of going into the steps. So the first step is identify the decision to be made and the scope of that decision. So you want to use the demographic information and identify who will be affected and served. You want to identify the stakeholders and all the affected parties. Make sure you're clear on who's going to be making the final decision. And then considering what marginalized populations that you may be affecting, and that there are just a list of some of the possible marginalized populations. So step 2 is assess the equity in the community context. So we want to engage those stakeholders that you've identified, making sure that we're communicating with them well to understand their priorities and concerns from their perspective, understanding again whose voice is missing at the table and how do we get that voice to the table and engage them, understanding how the proposed course of action will affect the known inequities. Will it reduce them, exacerbate them? Will it not have any impact? And then identifying the potential unintended consequences. Third step is analysis of the decision process. So project or map out the key alternatives will affect the communities and will it affect our UW-Medicine system-wide priorities and concerns? How do these alternatives impact UW-Medicine in our quest to become an anti-racist organization? We want to analyze the benefits and burdens for each of those alternatives that we have identified, looking upstream as well, not just what is right in front of you or what you think might happen, but how did we get to where we are? So really going back up and looking upstream to eliminate that disproportionate impact. And then prioritize the alternatives by the equitable outcomes and reconciling them with both functional and fiscal drivers. Step 4 is clarifying your purpose and the adverse impacts. So review what the proposal seeks to accomplish. Will it reduce disparities or will it reduce discrimination? Will it reduce inequities? Will it reduce the disproportionate impact of something that's already happening? Who's going to be negatively affected? How will the adverse impacts be prevented or minimized or eliminated? And are there better ways to reduce the disparities and advance our equity work than what you possibly are thinking of? Then step 5 is looking at advancing our anti-racist organization's decision-making and implementation. Does it further our anti-racist goals? We want to be able to communicate and engage with the stakeholders and the communities, our employees, and include a rationale behind the decision and making sure we understand who is being held accountable. Measure and evaluate the intended outcomes and collaboration with our stakeholders and those who will be affected. And then are we making sure that there are provisions to ensure we have ongoing data collection? Are we being transparent about the decision, about what data we are collecting and why? Are we going to publicly report this? How are we going to engage the stakeholders? Are we making sure that they are participating, fully engaged, and are we holding ourselves accountable to the stakeholders and the general public? And then step 6, we want to build in any ongoing learning and engagement, making sure we, at the beginning, what are our success indicators and progress benchmarks? Evaluate whether action appropriately responds to the stakeholder priorities and concerns. Learn with the stakeholders to adjust our actions and priorities. And communicate the progress to all the stakeholders and the affected community. And this is just a little summary of all of those steps, just kind of in one place. So that pretty much is the tool. And would be happy to take any questions. And I, again, apologize for all the noise happening outside. Hope you're not hearing too much banging and sliming, and probably going to be a chainsaw happening soon, but anyway. Questions, comments?
Thank you so much for sharing that. I was wondering if you might be able to share how this tool has been applied to certain policies already within our system, and just kind of thinking through or hearing about how that process went.
Yeah, I mean, the one that is pretty relevant, because about 95% of my meetings are all about this right now, is vaccines. So myself and Dr. Santiago Name are leading the vaccine distribution equity work group. And when we put our group together, and one of our first tasks was to figure out how do we get communications about the vaccines out to our workforce, and particularly our frontline workforce who are of limited English proficiency. We just took that whole, okay, this is our task, and ran it through the whole tool. And then we came up with our plan, which we have been implementing for, I don't know, a couple of months now, about communicating through online vaccine information sessions that we've done in 7 or 8 or 9 languages at this point. I just saw a couple of new ones we're putting on today, and now we're looking at, well, how do we get that message, how do we do the messaging that's going to be out in the larger community? And so we now have this framework of who are the stakeholders we're going to need to engage. What are the possible impacts of using one form of media or another form of media? You know, even though we are in this online world and not able to gather, are there certain communities for which that's just not going to work, and we need to get in person? For instance, Dr. Neme did go out to one of our community partners. They had a large number of Spanish-speaking frontline healthcare workers, and he went out in person and talked to them, because it just, they were not a group that was going to have access to online information. So yeah, that's one that's really relevant, and it worked really well. And you know, the goal is to have people have this tool, and to get them just thinking about this all the time. You know, it's great if you can take every decision and run it through this tool. That's not practical, right? But having done this for a few things, and really going through what can be kind of tedious, but it gets you thinking differently, right? So that next quick decision that you need to make, might just make you stop and think, whoa, wait, we don't have all the voices at the table to have that. Let's have another meeting and have, you know, bring in the other voices before we make that. So that's why we've also had requests for a shorter version that people want to be able to use just to do sort of daily operational type decision making. Kind of check, oh, did I do that? Check, 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 check. Okay, great. I think I have all of the things that I need in place to make this decision. Otherwise, as we well know, we make these decisions and then realize that we've had some really negative impacts on equity, and then we got to course correct or back up or stop, right?
Dr. Houston, does this tool exist in other forms at other institutions? Like, it seems like a simple process of like applying a equity lens like to a QI framework, but I'm just kind of shocked that this isn't being done other places. Like, how did this come to you?
So I wish I could say it was my idea. It was not. We borrowed heavily from the, so let me back up a little bit. The first time I knew about an equity impact analysis tool was in working with the city as a partner with the city of Seattle. The city of Seattle has their racial and social justice initiative, and they have a racial equity toolkit. It's online. I encourage you to go look at it. And what they have is the equity impact analysis tool. So in my previous role that was mentioned in my lovely introduction at Sound Generations, I was CEO there, and I had a board, as most nonprofits do, as all nonprofits should actually, and we were making decisions around budgets and cutting programs and strategic planning, and realized that the board members really didn't have that equity lens to look through when making those types of decisions that were really going to, really affect people's lives. We're going to cut a food program for seniors. Well, that means a whole group of seniors are not going to have a hot lunch, and that's their only source of having a hot meal for the day. So, so I put together not nearly as an extensive version of this tool as we have here, but used it there. And it was really helpful for the board because they would have just said, okay, we've got budget cuts, we've got to be fiscally responsible. That's our fiduciary responsibility to make sure the organization, stays financially afloat. And we're just going to cut. But once they had this lens to look at things through, and they had more conversations and we brought more voices in, we realized, oh, there are some alternatives that we can do to at least lessen the impact on specific communities that we just hadn't thought of. And the tool often will let you, the result is, what, we still got to do this, and unfortunately someone is going to be negatively impacted because in that case we had a finite amount of money, right? We're going to have to cut somewhere, but how do we lessen the impact? How do we partner better or do some other things? And this just gave a real structured way to do that. So having had that experience, and then coming here and realizing that we're moving towards, really focusing on healthcare equity and being an anti-racist organization, I realized the same type of lens was needed here. And so we then, about a year and a half ago, began to think about this and develop it. Yeah, and it really just came to fruition when I was sitting in a meeting and a decision had been made that it was a new meeting that I had just been invited to, and they were about to push through a decision on something that just all kinds of red flags went off, and I went, no, we can't do that. And so fortunately we did hold it up, and then we said, you know what, we've been just in our team kind of working with this tool and draft, and then we finally put it forward and used it for that issue and some others. So yeah. And as far as I know, we have not seen it from other organizations. We've had a couple of colleagues who have said, hey, I'd like to share this with another institution. And but again, it has come out of municipal jurisdictions. They've used it, City of Seattle, and I know other jurisdictions have had it, but I have not seen it in a health system like this.
Thanks so much for talking with us. I was wondering, would you be able to talk about you mentioned like 10 individuals or 10 groups, is that right, who are actively using the toolkit? Would you be able to talk more about who's starting to use it?
If I could remember who the 10 groups are. I know Valley Medical Center is one of them. Where is my list? Okay, let's see. I can get back to you on that with what they're with who it is. I'm sorry, I don't have that in front of me, but I can get back to you on that.
Dr. Houston, thanks so much for being with us and sharing about this work. It seems like such a cool lens and tool to apply to programs and decisions and different aspects of an institution like UW and UW Medicine. I was wondering if there's any developing mechanisms for accountability in terms of like when it will be used and how often it'll be used and what accountability there could be in terms of like the findings that are produced from the tool to avoid situations in different places where it might kind of become performative or underutilized, or the results don't lead to I guess the implementation of the findings.
Yeah, that's a really, really great question. And it's one of the things that we're thinking about is how do we institutionalize this so that there is some expectation that this is used. And right now, as we're piloting it, we you know, here at UWMS, we sort of socialize things around a lot to get a lot of buy-in, and that's kind of where we are right now. I would love for us to get to a place where that it is expected for at least certain kinds of decisions that this tool is used. And right now we're not there yet, but there's been so much positive response to it. I feel like that we have an opportunity to get there. For instance, as people are doing strategic planning and thinking about, new lines of business or cutting lines of business or new communities to serve, the large decisions that will impact all aspects of our organization. I would certainly like for us to get to a place where we use this tool. And then, as I said, people have asked for a shorter version of it to use just day to day. But you're absolutely right, and we need to get to a place where it is institutionalized. This is sort of the expectation, and then build in what those accountabilities are if we're not using it. Why not? And how are we rationalizing that?
Thank you.
Mm-hmm. Other questions?
Eva.
Other questions?
I have a question.
Yeah.
First of all, Dr. Houston, thank you so much for this talk. There's a couple of people who are interested right now in reevaluating our hospital policy about treatment of patients who are incarcerated, and I feel like this framework would be really, really important to basically to reevaluate that. How can we get in contact with you and the folks who have developed this tool to maybe partner with you?
Yeah, I think. Are you which facility are you with? Are you with Harborview?
The case that we were evaluating was at UW specifically.
Okay, because Edwin Lindo, who as I popped on, he was popping off, is working with a group at Harborview that is actually very focused on this, how we are working with our people who are both incarcerated and those who are in police custody. So, Edwin is part of our team in the Office of Healthcare Equity. I don't think we have talked with anybody at UWMC about this specifically, but we might as well just have one conversation about it. So I would say circle back to Edwin, and yes, he's already been in touch with several. He's had at least 2 conversations that I've been in with folks at Harborview about that.
Awesome, thank you.
Yeah.
This is changing the topic a little bit, but I was wondering if you could talk a little bit more about sort of recruitment efforts at large at UW and like efforts to retain faculty and fellows who are underrepresented in medicine.
Yes, absolutely. So as we well know, recruitment and retention of URM faculty, fellows, residents, students, and staff, even for that matter, is a challenge. But specifically speaking to faculty, one of the things that we have now is Dr. Kemi Dahl in her role as Director of URM Faculty Development. So she is working out of Trish Critic's office in the Office of Faculty Affairs to be very focused on particularly early career URM faculty and making sure that they have a resource, that they have the connections, the support that they need to be successful in the workplace. One of the things that we are now, or we're focusing on and have been, but it's a struggle, is collecting data on who is already here, sort of who's here, who applies to be here, who's being promoted, and then who is leaving. And that has been, it's been a struggle to get that information for lots of different reasons, from either HR or EEOC, but we are working on getting that. So that's the first thing we really need to know is who is here, who is underrepresented. And, we've tried various things, and, we certainly don't want to, go to leadership and say, could you just, eyeball it and tell me how many, Black staff, Black colleagues, Black faculty you have. So we're trying to get a way to collect the data, and it's just really, really complicated. But I believe we are making some headway there. So once we can get some real numbers, then we can target some recruitment. We are definitely working on revising the required training that people who are doing search committees have. Right now, there's an implicit bias training that people are required to take, and we're looking on updating and revising that and making those requirements much more robust, so that we have the most diverse candidate pools that we can possibly have, and that it's done in a real structured way. Because as you may know, right now it's sort of, well, we think we might reach out to this person or to that person or to that school to try to get a more diverse candidate pool, but there's no real structure and strategy around it. And so that's what we're working on putting together.
Dr. Houston, in a similar thread with the work you're doing to even understand who are your faculty members and staff members, has there been any discussion at a systems level about publishing maybe a list of BPOC providers for patients who want, a provider who looks like them or can share like certain experiences with them, since we know that certain patients would prefer, that relationship? Like, has there been any discussion about making that a resource available to patients if they want that?
We've had just some really brief conversations about that. We just in the context of how do we identify everybody first, because there are lots of really good reasons for us to have that information. And so yes, that definitely has come up, and it would make sense, right? Because we have now a list of providers who provide gender affirming care, right? And who are LGBTQ affirming care. So it would make all the sense in the world. We have to know who they are first. Yeah.
Houston, can I ask how long you've been trying to get this data and information about faculty at UW?
As long as I've been here, since 2017, and my colleagues who've been here longer than that have also been trying. It's because of just lots of reasons around when we collect data, when people come, we haven't told them we're going to use that data for anything different. And so it's held very closely. Upper campus is involved in it. It's one of my longest standing frustrations here at UW Medicine, but honestly, just in the last couple of months, I think we're making some headway. because everyone is asking the same question. This makes no sense if we are really committed to doing diversity recruitment and retention, and we can't even know who we have here.
If anyone from our admin is on this call or listening, I know for a fact that I've had applicants tell me that they're choosing not to come here, both in our program and other specialties, because when they look at the roster of faculty, they see mostly white male faculty, and they choose to go elsewhere. That would have otherwise been a great benefit to us.
Yes, I mean, we have, now there's conversation about doing cluster hiring and what that might look like. I know they're doing some of that on Upper Campus. I've just been involved in some of the conversations around doing that, and I will say I'm having just been in this role since 2020 of July, so just a little over 6 months. I've not been involved in faculty hiring at all. I know there are as I said, so I know there are conversations, just one or two that I've been in talking about cluster hiring. But as we do that, we want to make sure, if we are successful in doing that, making sure then we look at the retention. How are we making sure we retain those faculty, that they're going to have a good and a successful experience while they're here. So definitely the conversations are happening. And I'm told they're happening with much more intention than they have in the past. And so that's encouraging. Still frustrating, but encouraging. Other questions?
Dr. Houston, I want to change the subject a little bit to the bias reporting tool that we were just sent. If you could tell us a little bit more about what the process is going to be like when someone reports something, and what can we expect in terms of holding some people accountable for what's happening.
Yeah, so we just rolled out our bias reporting tool, and we're happy to say that it is being used, so that is great. That came out of realizing that there was a need for a place for people to go that was not just kind of the regular channels, back to your supervisor, back to your manager, back to HR. So we developed this tool probably over the last year and a half also. So it is online. There are a group of leaders that will take the report in conjunction with HR, our HR professionals, to make sure that we are adhering to our policies and laws that we have to adhere to when things are reported. There's some things that cannot just go unreported into a formal process, and then we will get back to the person and give a list of alternatives of how to follow up on that. We have both an anonymous and an anonymous option. We actually encourage people to give us their names and contacts so that we can follow up on it. It's obviously hard to follow up on something that's anonymous, but not impossible. If we have some information that it's a particular department and we keep getting a number of anonymous things from one department, we would follow up with leadership in that department or unit or entity, something like that. So that's kind of it in a nutshell. If you go to the tool, you will see all of the information on how to use it and what the process will be. But we roll out a tool like that, it's either people are going to immediately use it and we'll get just a flood of things, or we were also concerned that, oh no, maybe no one will use this tool. And that has not been the case, so we're happy about that. Anything else? Well, if you want to follow up with me, you have my contact information, and happy to follow up with anybody on anything? And as I said, you know, Edwin was here, and he's a great resource in our office as well. We now have Dr. Bessie Young as our new Associate Dean and Medical Director for Healthcare Equity. And then Dr. Leo Morales is our fourth leader, and he is really leading our work around our data, ensuring equity as part of our QI processes. He's very much involved in the vaccine equity distribution and data collection and dissemination. So we have lots of strong resources, and happy to hear from any of you.
Thank you so much for being here today and for answering all of our questions. We really appreciate it. And thank you again to everyone who organized the session today. It's been just a really great morning so far. I think we have—
Take care. Bye-bye.
No problem. I think we have time for about a 10-minute break or so. Lindsay, Anna, if that sounds, and Yinka, if that sounds good for you guys. And